La Escuela de Medicina y Ciencias de la Salud se fundó en Monterrey en el año de 1978, y es ahí donde está el Centro de Innovación y Transferencia en Salud, el Hospital San José y el Hospital Zambrano Elion. En Ciudad de México se encuentra la Unidad de Investigación de Enfermedades Metabólicas del Instituto Nacional de Ciencias Médicas y Nutrición, Salvador Subirán. En la ciudad de Guadalajara, el Centro de Ciencias de la Vida. En Chihuahua, la escuela es parte de Tec Salud, integrándose también el Hospital San José, Hospital Zambrano Elion, institutos y Fundación Tec Salud, formando un centro de atención, educación e investigación. Ser la mejor escuela de medicina y ciencias de la salud de Latinoamérica es nuestra visión, enfocándonos en bienestar, prevención y longevidad. Nuestros programas académicos: médico cirujano odontólogo, licenciatura en nutrición y bienestar integral, licenciatura en psicología clínica y de la salud y licenciatura en biociencias. 17 especialidades y subespecialidades médicas, 30 cursos de alta especialidad, una maestría y 2 doctorados. Nos caracteriza nuestro modelo educativo innovador, creando una experiencia transformadora con alianzas educativas en todo el mundo, 8 grupos de investigación con enfoque estratégico y más de 50 alianzas educativas en todo el mundo. Sociedades académicas para monitorear y apoyar a los alumnos, posicionándonos dentro de los primeros 5 lugares en el examen nacional para aspirantes a residencias médicas. Nuestros programas cuentan con acreditaciones nacionales que respaldan su formación, siendo la primera escuela privada que tiene convenio con la Secretaría de Salud del Estado de Nuevo León, a través del programa multicéntrico. Y somos la única universidad privada en México que figura en el ranking QS de Medicina en Latinoamérica. Ahora que nos conoces, explora, elige, libera tu potencial transformador.
Buenos días, tengan todos ustedes. Soy el doctor Oscar Valencia, coordinador de este espacio de educación médica continua. Y antes de dar inicio a nuestra sesión, les recordamos que todas las preguntas las podrán hacer a través del chat. Las haremos llegar a nuestro ponente al final de su presentación. También les pedimos que nos hagan favor de llenar una encuesta de satisfacción al final de la presentación, y la liga para tal fin lo podrán encontrar en el chat o bien a través del código QR. Les recordamos también, pongan su nombre completo en la pantalla, con el fin de que se facilite la elaboración de los certificados. Y en nombre de la Escuela de Medicina y Ciencias de la Salud del Tecnológico de Monterrey, les doy la más cordial bienvenida a nuestra sesión académica de pediatría. We're going to have a very special presentation today. Dr. Patricia Nash, she's going to address the Autism and Developmental Regression in Down syndrome. Very, very important issue for us. And before she starts, we're going to have a few remarks of his extended curriculum of Dr. Patricia Nash. She went to medical school at Indiana's University School of Medicine. Her residency in pediatrics was done at the Indiana University Medical Center. She has a fellowship in developmental and behavior pediatrics at the Ohio State University College of Medicine and Public Health and Columbus Children's Hospital. She also has a diploma in leadership education in neurodevelopmental disabilities at the Nissinger Center at the Ohio State University. She's a clinical associate professor of pediatric at the Ohio State University College of Medicine and Public Health. She's also medical staff at Nationwide Children's Hospital for the last 20 years. Prior to that, she was a medical staff at the Nissinger Center at the Ohio State University and Association of University Centers on Disabilities. She has clinical and research activities Center on Attention Deficit Hyperactivity Disorder, Behavioral Problems, Autism, Down syndrome, and general developmental disorders. She's involved in the Autism Program and Children Developmental Center, and she's the director of Down Syndrome Clinical at Nationwide Children's Hospital in Columbus, Ohio. Welcome, Dr. Nash. It's a pleasure to have you with us. So I'll give you the floor.
Hello. Hi. It's a pleasure to be here with you this morning. It's an honor and privilege to be able to present to you. And I was very pleased when I heard from my friend, Dr. Lozano, when he asked me to share with you this morning. We got to know him when he was doing his fellowship here at Nationwide Children's Hospital, and he finished up last year, and we miss him. But it's good to see you all today and to be with you. Let me see about sharing my slides. Okay, I had it where I could see the are you able to see my slides right now?
Not yet.
Okay. Initially, when he was speaking, I was able to see.
I think it's coming.
Oh,
all right.
There
we go. Yep.
Can you see them now?
We are seeing the, not the slideshow yet, but you have PowerPoint open. So probably there, just start the presentation.
New
The
share. As he was talking, it had the button, the green button that said share screen, but then it went away.
We are seeing it. Now you just need to start the slideshow.
Oh, okay.
Yeah.
Okay.
Up there.
Yeah.
Right there. Yeah.
Now what are you seeing?
The slideshow hasn't started. You just have PowerPoint. There we go.
Okay. Now you see the title slide?
Yes.
Excellent. Okay. So I was asked to speak on autism and developmental regression in Down syndrome, which to me are two different things, two different animals. So I will spend the first part of the talk talking about autism and Down syndrome, and then later talk more about the developmental regression piece of it. Of course, there's overlap, but I think the presentation is very different. So to start off, I wanted to do just a very quick overview of both Down syndrome and autism. I know that you are all very much familiar with both conditions, but I wanted to try to do sort of a compare and contrast between the two and point out the similarities and the differences. They are so basically different and yet have some overlapping symptoms. So first off, the incidence of autism, or autism spectrum disorder, as it's formally called, in children who have Down syndrome is higher than children who do not have Down syndrome. So sometimes when I'm working with medical students, they seem a little surprised that children with Down syndrome can also have autism. And I explain that, yes, not only can they, but it's actually more common. It's a higher, like I said, higher incidence of autism in children with Down syndrome. The estimates vary anywhere between 5 to 39%, which is a very wide range. I think it's probably more between, I've also seen 16, 17%, which I think is more accurate. So 16 to 18% of individuals with Down syndrome will also be diagnosed with autism sometime in their lifetime. I've also read that the rate of autism is up to 30 times greater in the Down syndrome population than in the general population. The diagnosis of autism in a child without Down syndrome is often made around age 2 to 4. Sometimes it's later, depending on the severity of symptoms, but I would say on average, and for your most typical classic forms of autism, it's when they're toddler to preschool age. In a child with Down syndrome, the diagnosis of autism can be made much later due to a variety of reasons that we're going to get to. Often it's because the symptoms of autism, like speech delay, for example, are attributed to the Down syndrome, including, behavior problems, not just speech delay, but behavior problems, developmental delay. Oftentimes clinicians and parents will all blame it on the Down syndrome. And again, like I mentioned, there's a lot of overlap in the symptoms of autism and Down syndrome. A few statistics: Down syndrome occurs in approximately 1 in 700 live births, according to the Centers for Disease Control. In the US, there's about 6,000 babies born with Down syndrome every year. As you know, the diagnosis is made by chromosome analysis. Now, as the prenatal testing improves and is more and more sensitive, it's made prenatally more often, but still quite a bit of the time it's made postnatally. So even if there's suspicion from prenatal test results, the diagnosis is confirmed after the baby's born by doing a karyotype on the baby's blood. So it is obviously a genetic disorder that results from when a child has 3 copies of chromosome 21, also known as trisomy 21. 95% of cases of Down syndrome are caused by trisomy 21. The other 5% are made up of translocation and mosaic Down syndrome. So the diagnosis, my point being, the diagnosis is definitive. It's unequivocal. You don't have people arguing about whether someone has Down syndrome or not. You can confirm it by the lab testing, and the diagnosis is made very early on at the time of birth, if not before. Occurs equally in boys and girls, occurs in all races, ethnicities, socioeconomic backgrounds. No environmental risk factors, but we know the risk for an individual woman increases by her age. So in contrast with that, autism, although we believe there are genetic factors, it's not caused by a single identifiable genetic disorder or genetic abnormality. It cannot be diagnosed with a genetic test. There's no prenatal test available for it. You can't diagnose it at birth. It's likely to be multifactorial, possibly not a single entity, but a combination of things. Maybe a group of different disorders with a similar presentation. In other words, we don't really know exactly what causes autism. Most recent estimates are that autism spectrum disorder occurs in 1 out of 44 children. It's funny, I look this up in the CDC, Center for Disease Control website, every time I give a presentation that talks about autism. And it seems like every time I check, which is every year or two, the number changes. So it used to be, 1 in 50. Well, it used to be much lower years ago, but in recent years, it has changed from 1 in 50 to 1 in 89 to 1 in 59, and now 1 in 44. So it seems to be more common, or at least it's being diagnosed more frequently now. Autism is 4 times more common in boys than in girls. It also occurs in all races, ethnicities, socioeconomic backgrounds. And as I mentioned, it cannot be diagnosed prenatally or at birth, and there's no characteristic physical features, in contrast to Down syndrome, which is, usually easily recognizable. As far as genetic factors go, as I mentioned, we do feel that there is a genetic predisposition for it. And the reason we think that siblings of individuals with autism have a much higher incidence, much higher chance of also having autism. Twins, there's a high concordance rate between monozygotic twins. Children born to older parents are higher risk for developing autism. Not necessarily just having an older mother, but older parents in general. So, as we explain to parents all the time when we're diagnosing children with autism, there's no medical test for it. The diagnosis is a behavioral diagnosis. One of my colleagues likes to call it a looking and listening diagnosis. So it's looking at the child, listening to the parent. Diagnosis is based on behavior and development. It's based on both the absence or delay of normal development and the presence of atypical behaviors. The diagnosis is based on symptoms reported by the parent, also direct observation and developmental testing. Here at Nationwide, we have a process which is an interdisciplinary team evaluation for children who are referred for autism. And it includes taking a detailed history, doing a physical exam, having a speech evaluation, and then also administering a test that I'll get to in a minute to look for signs of autism. So just as I mentioned that Down syndrome is at its basic, it's a genetic disorder. Autism is considered more of a mental disorder, and it is described and defined in the Diagnostic Statistical Manual of Mental Disorders, or the DSM-5. So just to define autism, again, I don't want to spend too much time on this, but to define autism, it is made up of persistent deficits in social communication and social interaction across multiple contexts. This is further described as deficits in social emotional reciprocity. So what I think that means is, does the child, can you have a back and forth conversation if the child's not verbal yet, a back and forth interaction with the child? Even typically developing babies, you can see an interaction between parent and child where the parent says a word, the child makes a sound, the parent smiles, the child laughs, they're back and forth. That's what we mean by social emotional reciprocity. There are deficits in nonverbal communication. So we always ask about children, do they point? So pointing is a very, very powerful tool. That's an example of nonverbal communication. And then as the children get older, are there deficits in developing, maintaining, and understanding relationships? And then the other part of autism is restricted repetitive patterns of behavior, interests, or activities, manifested by stereotype repetitive motor movements. So examples of this would be hand flapping, twirling in circles, running back and forth, walking on their toes, lining up objects, staring at objects, that type of thing. So those are the kind of characteristics you would see in a younger child presenting with autism. You can also see insistence on sameness and flexible adherence to routines, ritualized patterns of behavior. This might be, the child who gets upset if you take a different route to school in the morning, if you change things up in the evening. If their routine is different, they become very upset about it, very dysregulated. Another part of it is highly restricted or fixated interest. So this is something you could see in any age child. It could be something motor, like twirling or dangling a piece of string. I've actually seen this occur quite a few times in children with Down syndrome who also have autism. So they might have a piece of string and they just flick it back and forth and twirl it, and they can do that for hours. For maybe higher functioning children with autism, it might be an intense area of interest that seems unusual. It could be something like helicopters, generators, things that you wouldn't think that children would be that interested in. And then finally, there's often a hyper or hypo reactivity to sensory input. We describe this as sensory sensitivity, sensory processing disorder. They might be very sensitive to loud noises, bright lights, clothing. The tags in their clothes bother them. They have to have the tags cut out of their clothes. Their socks have to be just the seam of the sock lined up with their toes, or else they can't move on to the next item of business. And then the symptoms must be present early in the developmental period. Symptoms should be, in order to diagnose autism, the symptoms are causing significant impairment in social, occupational, or other areas of current functioning. So, we've seen kids who are maybe a little different, a little quirky, but if they're doing well and they're doing fine in school and they're doing fine at home, then maybe the diagnosis doesn't fit for that person. The disturbance is not better explained by intellectual disability or global developmental delay. So this one I wanted to explain a little bit. So the symptoms you're seeing is not explained by intellectual disability in cases of autism. Intellectual disability and autism do commonly occur together, but to make a comorbid diagnosis of autism and intellectual disability, the social communication should be below that expected for the general developmental level. So, for example, if you have a child who is delayed, say they're 10 years old, but intellectually, developmentally, they're more at the level of a 5-year-old, but their social skills are even below that, substantially below that, then that would help us to come to a conclusion of autism fitting for that child. All right, let us move on to similarities between Down syndrome and autism include speech delay, number one. I would say that all children with Down syndrome have some degree of speech delay. And not all children with autism have speech delay, but most of them do. And often that's the first symptom that comes to light. Often we will ask parents, when did you first become concerned about your child? And they'll say, when they were 18 months, maybe close to 2 years, and still hadn't said their first word yet. Often speech delay is the thing that they notice first. I would say that most, or if not all, children with Down syndrome have some degree of intellectual disability. The estimates vary, but maybe 70 to 75% of children with autism also have intellectual disability. And children with either diagnosis can engage in repetitive activities. So my point here is that they are such different disorders, and yet they have these three things in common, which is why sometimes making the diagnosis can be difficult. The differences that make them stand apart: in Down syndrome, social interaction is often a strength. Individuals, very young individuals with Down syndrome often use both verbal and nonverbal communication. I have seen many toddlers with Down syndrome who are nonverbal. They might just have 1 or 2 words, but they are experts at nonverbal communication. And I see this all the time in our clinic. And I like to point it out when I have residents with me that they have great eye contact. We walk into the room, the child makes eye contact, immediately comes over to greet us, maybe touches our badge and makes eye contact with the parent, to share that they're meeting someone new. They smile, they nod, they have great facial expressions, they wave. And I like to point that out, that there's a lot of social interaction going on without using any words at all. In autism, of course, social interaction is the weakness and communication is impaired. Diagnostic overshadowing, like I said, attributing symptoms which could be due to autism to Down syndrome. And I think this is often what delays the diagnosis. So that's why maybe a child with Down syndrome they had symptoms from the beginning, symptoms of autism from the beginning, but they're 5 years old and everyone thought they weren't talking and they weren't socializing because of Down syndrome. And so they aren't brought to anyone's attention. Just a little schematic, but Obviously, this isn't to any type of appropriate scale. So I think of intellectual disability, if you try to make it more to scale, intellectual disability would be bigger and Down syndrome and autism would be smaller. And then I like this little table here, which also compares the two. So delayed language in both cases, social skills, so that's the one that differentiates the two. Social skills are intact, more or less, in Down syndrome, and then impaired in autism. Repetitive behaviors can be present in both. So just because someone with Down syndrome engages in repetitive behaviors doesn't necessarily mean they have autism. I would explore more the social interaction piece of it. Autism is defined by lack of or impairment of social skills. It's not necessarily defined by the repetitive behaviors. You know, I've had parents come in where their child is otherwise doing okay developmentally, but they engage in some type of, you know, they spin an object. And so the parent says, oh, I was afraid they might have autism. So how do you diagnose someone with Down syndrome with autism? The same way you would diagnose anyone, a child without Down syndrome. So ideally, a child suspected, so this is applying to children with and without Down syndrome. A child suspected of having autism should be evaluated by a diagnostic team, including a medical provider, a psychologist, and a speech therapist. Other members of the team might include an occupational therapist, a social worker, and a psychometrician. Now, Dr. Lozano knows what a psychometrician is, but most people I talk to that don't work here are questioning, what is a psychometrician? So they are an assistant or a technician who helps the psychologist. They administer tests. They are trained and experienced in administering diagnostic tests to children. They're not licensed, and they don't have an advanced degree in psychology, so they can't write the report or interpret the data. But they help the psychologist, and they are able to help the psychologist see more patients. So the tools used, as I mentioned, there's no medical test for autism, but there are tests, but they are more either interview, questionnaires, or observations. The two gold standards for diagnosing autism are the ADOS, which is the Autism Diagnostic Observation Schedule. That is a play-based assessment where the trained person, like the psychometrician, administers the test. It looks like they're just playing with the child. They have toys on the floor, blocks, like different bubbles. They have this part that's a happy birthday party. So the examiner is presenting these things to the child, and they're looking at the child's response. You know, how hard is it to engage the child in these play activities? Is the child right there in with them, engaging in pretend activities? Or are they wandering off and looking at the wall and, you know, looking over here, and the examiner has to try really, really hard to pull the child's attention back. So that's what the ADOS is. The ADIR is the Autism Diagnostic Interview revised. That's more of an interview for the parent. It's long, it's extensive. There are different versions of it. I believe the long version can take up to 3 hours to administer. The short version, maybe an hour and a half. So, so we don't use it all the time, but there are some cases where we use it. It's often used in research purposes to gather data. Ideally, the clinician performing the evaluation should be familiar with children with Down syndrome. If you don't want someone who says they've never tested a child with Down syndrome before doing this type of thing. Primary care providers can screen for autism in children with Down syndrome the same way that they would screen children without Down syndrome. The MCHAT, which is the modified checklist for autism in toddlers, can be used to evaluate social skills in children with Down syndrome. If a team evaluation is not available, then autism diagnosis can be made by a qualified, experienced clinician. General pediatrician can make the diagnosis, absolutely. developmental behavioral pediatrician, psychiatrist, psychologist, pediatric neurologist, neuropsychologist. So it doesn't have to be someone from a specific discipline. Anyone who's had the experience and the training can diagnose autism. Of course, the earlier the diagnosis of autism is made, the better. The child can then access services and resources designed to manage autism, starting with getting them into appropriate therapy. For the very young children, starting with speech therapy immediately, checking and making sure their hearing is intact, referring them for behavioral intervention, and then as they become school age, then looking at autism-specific schools and educational programs geared for children with autism. I just wanted to touch on ABA. ABA stands for Applied Behavioral Analysis, and it is really the best treatment for autism. And again, I'm referring to children with or without Down syndrome that have autism. ABA therapy applies theories of how behavior works in real life situations. So the goal is to increase behaviors that are helpful and decrease behaviors that are harmful. Positive reinforcement is used to increase desirable behaviors. Harmful behaviors are decreased by not resulting in any reward. So the therapist would reward the child for doing things that maybe we want them to do. If they're not responding to their name, then they would work on that. They call their name, and if they do respond, then give them a reward. The more they do it, the more reward they get, and then moving on from there, getting them to follow a direct command or answering questions, keeping their attention focused, any of that. So positive reinforcement to increase the behaviors that we want them to do, and then trying to decrease harmful, so tantrums, things like that, trying to teach the child that they're not going to get any reward from tantruming. ABA therapy programs can help with improving their language and communication skills, their focus, attention, social skills. I believe that children who start ABA therapy early are more likely to be able to enter school on time and go to a school for regular, typically developing children, and it decreases problem behaviors, improves quality of life for the whole family, not just the individual. We try to keep in mind that the whole family is affected by a child with this disability. Touching on regression now. So when I think of a child who has Down syndrome and becomes diagnosed with autism, I think of a child who's younger and has speech delay, never really learned how to talk. Again, they go from age 3 to 4 to 5, and at some point the parent or the doctor realizes, there's something different. There's something very different about this child, different from other children with Down syndrome. When I think of regression, I think of a child with Down syndrome who talked later, but by the time they're 4 or 5, they're talking. They're able to go to school. They're very interested in friends, very interested in playing, have relationships with others. But then as they get older, they go through a period of regression where they lose a lot of the skills that they once had. So oftentimes this is seen in older childhood or adolescence, I would say between the ages of 10 and 15. It can be very heartbreaking because for the family, this is a child that was very much engaged in playing with the other children, very much an integral member of the family, and then they start withdrawing. They start spending more time in their room. They spend more time engaging in repetitive activities, like I mentioned about the twirling of string or playing with a floppy stuffed animal and doing this with it, and they do that instead of actually playing with the other children. There have been 80 published cases of developmental regression from 9 studies, characterized by loss of skill, mood changes. So often their emotions become kind of muted, where they just don't seem like themselves anymore. They don't get real happy. They don't get real sad. They're just kind of flat affect. They can seem to have a lot of repetitive thoughts and behaviors. Like I said, the onset can vary, and the onset is gradual. It doesn't happen overnight. There was a parent once who showed home videos, of what the child was like over the years, and it was astounding how when the child was younger, they were playful, playing with dolls with their sister, and then a few years later, they weren't really engaged, and then at that time when she gave the presentation, the child just really was almost catatonic, didn't really want to do much of anything. Again, the mean age of onset is maybe 15 years, but it ranges widely. Changes in motor activity, again, being less active, changes in speech, even changes in their sleeping and eating habits. So this phenomena is recognized. Many clinicians that see children with Down syndrome have seen it, have described, we've talked about it at Down syndrome meetings. There's several different descriptive terms. I'm not sure that anyone if people have really agreed on a specific term for it. The best one, I guess, that I've seen is Down syndrome disintegrative disorder. It's also called regression, disintegrative disorder, catatonia, acute neuropsychiatric disorder. There have been, several papers written about it, but there hasn't been an agreement on exactly what it is. In some cases, decline in functioning can be rapid. Sometimes it can be very slow. Before the regression, one patient was described as having higher than expected adaptive functioning. So as I'm sure you've all seen, children with Down syndrome can vary quite a bit in their abilities. You have some kids who are very high functioning, they're verbal, they're toilet trained, they go to regular schools, they have lots of friends. That was the child that was described here, was able to play the piano, could read, was even working part-time. And then there was this progressive slowing in their motor movements, periods of freezing where they just stopped moving altogether, grimacing, posturing, staring, didn't eat very well, had to be encouraged to eat. So if you were to see a child like that, it is very important to rule out a medical condition that could be related to the regression. So as the medical clinician, we need to rule out medical problems that are associated with Down syndrome. Dr. Lozano probably went over this in the last talk when he went over the healthcare guidelines. So these are all medical conditions that are at higher, that children and adults with Down syndrome are at higher risk for, and they can appear as regression. So hypothyroidism, or thyroid dysfunction, celiac disease, hearing loss, vision loss, obstructive sleep apnea can definitely affect behavior and moods. Other less common medical conditions include atlantoaxial instability, vitamin deficiency, especially vitamin B, B12 and vitamin D, seizures, victim of physical or sexual abuse. I've heard of this happening before too, where the child really couldn't explain what happened to them, but they were the victim of abuse, and that caused the regression. And it took a long time to figure that out. Psychosocial stressors, so change in caregivers. If, for example, the primary caregiver is no longer able to care for this child because of their aging or whatever reason, and they have to live with a different adult now, moving, finishing school, meaning that they're 18 or 19 or 20, so they've technically finished high school. Well, now what do? Now they have no place to go. They stay home all day. They have nothing to do. So that can lead to regression. Sometimes even changes in the family dynamic. I saw one family where the youngest child had Down syndrome. As they all grew up, the older children all moved out. They went on to college and moved on to becoming adults, and the youngest sibling regressed. They didn't have their older siblings to play with, to interact with. So the medical workup should include tests to look for those medical conditions. So looking at the thyroid function tests, the two screening tests. Well, the screening test for celiac disease is the tissue transglutaminase, looking at vitamin levels, checking their hearing. So again, referring to audiology, ophthalmology to check their hearing and vision. Sleep study to look for obstructive sleep apnea. So all things to consider in a child or young adult with regression. Looking for signs of atlantoaxial instability, and also screening for stressors and depression. Because the child may not be able to answer questions, this is likely to be completed by the parent or caregiver. Children and adolescents with Down syndrome can have anxiety or depression just like anyone else. Consider EEG or MRI. Those are less helpful, probably would be ordered only if you thought there was a clinical indication. As I said, evaluate for mood disorders or mental health disorders. I have seen adolescents with Down syndrome who have anxiety, who have depression, who have OCD. The diagnosis, like I said, can be harder to make, but they do respond to the same treatment that anyone else, that you would prescribe for anyone else. Counseling, psychotropic medications. I have a number of adolescents with Down syndrome who are on antidepressants or anti-anxiety medications, antipsychotic medications like Risperdal. In some of the studies on children with this Down syndrome disintegrative disorder, they've been treated with benzodiazepines and it seemed to help. And there's been a couple case reports of electroconvulsive therapy, ECT. Now that, of course, you would refer to psychiatry for that type of therapy. So referral to psychiatry can be helpful. Referral to neurology also, another possibility. There's some thoughts that there was a paper written that immunotherapy has been used to treat the Down syndrome disintegrative disorder. And that's with the idea that this regression is somehow caused by an autoimmune disorder. We know that children with Down syndrome are at higher risk for autoimmune disorders, and that's somehow related to the regression. All right, so the last few slides are my references. Okay, so.
Well, thank you, Dr. Nash, for your presentation. We have several questions for you.
Okay.
The first one, it says from our audiences says, how can we identify nodal sensorial disorders in autism and Down syndrome and not misdiagnose them?
How can you repeat the question?
How can we identify nodal sensorial disorders in autism and Down syndrome and not misdiagnose them?
Neurosensory disorders?
Yes, that's what the question says.
So I think, are you referring to maybe sensory processing disorder type of situation?
Yes, probably that's what they are asking. I think so.
Okay, so that comes up quite often. And I usually explain to people that sensory processing disorder is not really a medical diagnosis. It's not something that medical staff would diagnose. It's more in the realm of occupational therapy. So I usually refer children to an occupational therapist for evaluation for sensory processing disorder, sensory integrative disorder. Now they can coexist definitely in autism and with Down syndrome, but it's very, very common for someone with autism to also have a sensory processing disorder.
Okay, and another question is, can stereotype movements be treated if they are severe?
Yes. Well, I'm not sure if they mean by medication. There really isn't medication treatment for stereotype disorders. The best treatment probably would be the ABA therapy, and it would involve rewarding the child for not engaging in the stereotype behaviors, which is tricky. You know, I think of ABA as being more easier to implement if you're trying to encourage a child to engage in a certain behavior. So for example, if you're trying to get them to, if you're trying to get them to eat a certain food, then you give them reward for doing that. If you're trying to get them to stop doing something, that's harder. It's possible, but it's harder to do. So it's you have to reward them for a certain amount of time of not engaging in that behavior. So if it's something they're engaging in all the time, the reward has to be frequent at first. For, you know, if you don't engage in that stereotype behavior for 30 seconds, you get a reward. And then maybe for a minute, you have to not do that behavior for a minute to get the reward. And then you keep expanding. Now it's 2 minutes, then 5 minutes, and 10 minutes, until finally they can go for a long period of time without doing that activity.
Okay, thank you. Is another question, is the incidence of depression and anxiety higher in inclusive schools? Does homeschool have an advantage?
I don't know if there's been any studies to look at that. I think that most children remain in the public school system, and then they might be going to a special school within the public school district. Some kids will be pulled out and placed in private schools, which may or may not be helpful. The schools that are designed for kids with autism, I think that definitely, if the child has autism, they do better in a school that's designed for children with autism. I don't know how things are there. Here, those type of schools are private, they're expensive. Most people can't afford them. But there are grants and scholarships that people can apply for to pay for that type of setting.
Is there any report of Rett syndrome on these girls with their regression?
In Tourette's?
Rett syndrome.
Oh, Rett.
Oh, Rett.
Mm-hmm.
Oh boy.
Cool.
I don't know of any, and I think, you know, Rett syndrome is a genetic disorder. I think that their mortality is, you know, I'm not sure what the average life expectancy is, but I think it's lower. I don't know how many of you all remember the DSM-4 diagnostic, the DSM-4. So back then, autism spectrum disorder was an umbrella term, autism spectrum disorders. And then there were 5 distinct disorders under that heading. Rett syndrome was one of those. So the others were childhood disintegrative disorder, which actually kind of describes what I see in kids with Down syndrome. Childhood disintegrative disorder was very similar to autism, but had a later onset and involved regression of skills. And then the others were more classic autism, Asperger, which we don't use that term anymore because it's not in the current DSM, but that was autism in someone who doesn't have speech delay, but they still have the impairment in social interactions. And then the 5th one was autism spectrum disorder, not otherwise specified. So ASD-NOS, and that we use that term for kids who seem to have some features of autism, but not enough to meet the diagnostic criteria. But, you know, when they came up with DSM-5, they decided to get rid of this 5 individual disorders. It was sort of like splitting hairs sometimes, trying to decide which one they fit in. And so now they just call it all autism spectrum disorder. But Rett was one of those, and now it's not even considered an autism spectrum disorder anymore because there's genetic basis for it.
Thank you. Juan Francisco, do you have any other questions that you'd like to address?
Well, first, Ken, thank you. Very, very interesting at least as we are those who work with Down syndrome kids, we know all of this can happen. So being aware of, I think it's very important. So I think one of the questions could be like, have you seen any correlation or more of being like a little bit preventive or proactive in reducing the risk of regression? You know, we know that hypothyroidism can cause it, sleep problems, behavioral problems. So if you are on top of this, managing it, is there any linkage with decreasing the risk of regression?
I haven't read any studies looking at that, but you're right. I think screening for all those things and making sure that you're monitoring, you know, those things is helpful. Also, I think something we can't do anything about, but the socio stressors, the things that are going on in the child's home also probably plays a large role in that. I've seen some children who present to our clinic at an older age, maybe 10 or 11, and I haven't seen them at all, or maybe I haven't seen them for years. And it turns out that they were in a, you know, maybe a neglectful environment. I had one child who I saw when he was very young. He didn't come for several years. When he came back, he was with an aunt or a grandmother, and it turned out his parents had drug addiction problems. And it sounded, I heard more about it later, but apparently there wasn't food in the house. There wasn't anyone actually watching the children. And I think that was very detrimental. And that child did experience some regression skills.
Yeah. And I think following on that, like question, probably just deviating a little bit, you know, they asked about Rett and Down syndrome, completely different things. But, you know, when would you think about doing more genetic testing on a kid with Down syndrome? Because Down syndrome is one thing, they can have other things.
Right, that's a really good question. And, you know, because I didn't talk about this, but as you know, when a child without Down syndrome is diagnosed with autism, one of the standard recommendations is genetic testing. And again, we always tell parents the genetic testing is not to confirm the diagnosis of autism, it's to look for a different genetic disorder that could be presenting as autism. So for example, Fragile X would probably be one of the more common ones. Various deletions, duplications can present that way. So what we normally order is a microarray and Fragile X for a child presenting with autism. So like you said, so if a child already has Down syndrome and then is later diagnosed with autism, should we do more genetic testing? Yeah, probably we should. Because, well, and also when they were diagnosed with the Down syndrome, likely the test that they did was just a karyotype, which is basic, very looking at, you know, the number of chromosomes. That's a very simple, basic genetic test that the turnaround is pretty quick because they know exactly what they're looking for. They're not looking for Fragile X. They're not looking for, with the microarray, you can see all these smaller deletions and duplications. They're not looking for that when they do the karyotype at birth. So yes, that's a good point. I think that children with Down syndrome who are diagnosed with autism should undergo more genetic testing. Now, at that point, do you want to order it yourself, or do you want to send them to the genetics department to let them do it? That's, you know, that's debatable. You might consider sending the child to genetics for further evaluation.
Yeah. And I think just going back to also that question, you know, they were asking about like neurosensory, and I mean, how can you define them or not getting confused with those type of concepts? Specifically probably about autism and kids that come with sensory problems. As you were saying, it's not a proper medical diagnosis, but that it can, I mean that there's something else that we're missing. and not properly just some sensory overload or
Right.
sensitivities, which I think that's probably the last thing. But yeah, I think Dr. Valencia, I don't think there are any other questions. Have you received any others?
No, we don't have any other questions.
And I think that maybe addressing the sensory disorder can help with the behavior a lot, because I think when parents, when they bring their children back, the primary concern is behavior problem, tantrums, not being able to get the child to cooperate with getting dressed or getting in the car or going to school. And so if you can treat the sensory aspect of it and improve their behavior, then I think that the whole child's functioning would improve both at home and at school.
Sure. Yes. Yeah. All right. Well, Patty, I think those were all of the questions that we received. So thank you.
You're welcome. It was a pleasure, and it was a pleasure seeing you and seeing all of you today.
Thank you. Thank you very much, Dr. Nash. Thank
You're
you
welcome.
for being with us and sharing your knowledge and your experience with us. Thank you very much. We really appreciate it.
You're very welcome. We'll see
Have
you
a good
again
day.
sometime.
Have a good day.
Yes.
You too.
All right. Bye-bye.
Bye.
Muy buenos días a todos, tengan todos ustedes y también les recordamos llenar la encuesta de satisfacción, ya sea a través de la liga que está en el chat o a través de este código QR. Que tengan un excelente día.